So let's get to Roy Rosin, Chief Innovation Officer at Penn Medicine, someone I've called the smartest Philadelphian you've never heard of. And Roy is a sui generis thinker when it comes to what innovation is, and I want to get to that. But Roy, you mentored under a legendary coach. Bill Campbell was the Columbia University football coach in the 70s, who then went on to coach Silicon Valley into being. He literally mentored Steve Jobs, Google, Jack Dorsey. The list goes on and on. Wow. It's as if Bill Belichick were the coach of the Eagles, the Giants, the Cowboys, and the Patriots. He was your mentor. What did you learn from Bill Campbell, and how does it apply today?
So I think everyone has their own take on Bill. You've seen the books that have been written by Eric Schmidt and others, and it's so interesting. I think we each have our own version of Bill. When he passed away recently, it was really an amazing thing where on social media, we each started telling our stories about him. And what became clear immediately is there were about 1,000 of us who thought that we had his undivided attention and that, he loved us more than anyone else. And he somehow managed to make, an incredible number of people feel special, which is, that's amazing in and of itself. I think, Bill was an incredible leader. He was an incredible people person. And I think his success in some ways, was just because so much of business is about humans. And business is fundamentally human. And Bill had tremendous insight. He had tremendous insight into people and motivations and business situations. He was very smart. He understood business very well. But I think the thing that I remember most about Bill is that, any one of us would have followed him up any mountain that he told us to charge. He really made you feel special. He made you feel important. He paid attention to me before I actually deserved it, which I always found interesting. I came out of undergrad. I hadn't distinguished myself at all, and it was an interesting thing. Bill had a technique that I still remember really clearly, and I think that he found engineers less political and more trustworthy in some ways than other roles in the company. And he would talk to engineers, both because he liked them and he knew that building things is what we were all about then. But that if he found great talent, that talent knew talent, that they would tell him who else was useful. And I think the only thing that probably distinguished myself then is that I was an MBA who didn't think I had all the answers. And so I remember that he talked to two of the lead engineers about who to pay attention to, and they mentioned my name. And that was probably the luckiest thing that ever happened to me, because he did take me under his wing. And to be clear, I also had Scott Cook, who's just an absolutely brilliant entrepreneur, and I learned an amazing amount from Scott as well. But Bill could solve problems in ways that were just remarkable. And that got at sort of the human behavior element that we're probably only beginning to understand in science right now.
Well, that leads right into the question about what innovation is, because I remember you saying that one of the things that Bill emphasized, and that I think you emphasized, is that we make a mistake when we think of innovation as synonymous necessarily with technology.
Yeah, it's really true. Synonymous with technology, synonymous with creativity, synonymous with invention. I find them all problematic. I think technology is the only way we really scale innovation. It's very hard to scale new things without technology underneath it. So I'm obviously a big fan of technology and find that it has changed the world tremendously, obviously. But it is different than the innovation itself. I mean, when you put innovation in juxtaposition to creativity or invention, like creativity is sort of coming up with new things and invention is bringing them into the world, inventing something new. I think all the way back to my Intuit days, I've always thought of innovation as more capturing value. Like if you can't capture the value you've created, or if no value gets created from your invention, it's not really innovation, it's more invention. And so that's the way I like to make it, distinguish it, I guess, from some of the other terms. But it is it's probably the most overused word out there nowadays. It's one of those words that because it now means everything, it means nothing. And in fact, lately I've been saying creative problem solving. I find myself being drawn more to terms like creative problem solving than innovation, just because it is such a beaten up, overused word nowadays.
Well, and if you have one mantra, it appears to be fall in love with the problem, not the solution. What does that mean, and how? Give me some examples of how you follow that dictum.
Yeah. So that I think first time I ever heard that said, I think, was Scott Cook, and he brought with him from some of the consumer goods and consumer packaged goods from Procter & Gamble this method of you need to get deeply embedded, you need to get deeply immersed, you need to understand what everyone else in the world has missed, and the stories that I kind of grew up on were these stories of things aren't always what they seem. And actually I can sort of like compare my first 2 days, my first day at Intuit, my first day at Penn, and both first days had an example. I was told the first day of Intuit, it was about 30 years ago or something, I was told the story of the slow elevator story, as some people call it. It's one of these myths that goes around the internet, and it's who even knows if it's real anymore, but it's a story of everyone complaining about how slow the elevator is, and the building is debating whether to replace the elevator or not. And, there'd be a multi-million-dollar project, and while they're debating it, over the period of weeks, the problem goes away, and they can't figure out why the problem goes away. And they go out and they find out that the maintenance crew had installed mirrors by the elevator. Now, everybody was sitting there, instead of being annoyed waiting, they were checking their tie, and they're putting on lipstick, and they're checking their hair. And, the problem wasn't necessarily slow elevators. It was the perception of the wait, or, sort of unproductive time, not just sort of the wait itself. Because once they were distracted and using time productively, checking things in the mirror, they weren't annoyed anymore. You fast forward to my first day at Intuit, and there had just been an innovation tournament with a lot of really good ideas that had been fleshed out. And one of them that had come from several different people was online scheduling. And online scheduling was something I still believe in. It's basically OpenTable, but for doctors instead of for restaurants. And a bunch of really smart people said, I really want to do this online scheduling idea. And I knew nothing about healthcare, and I knew nothing about the context. I literally just walked in the door. And I had been asked to kind of help move some of these forward. And as you go around the room and you're asking people, tell me, help me understand, like what would be good about online scheduling, and I kind of got it because I was already using OpenTable. It sounded so wonderfully convenient. But the stories were fascinating, right? It's like the first person says, well, I need a dermatologist, and I can't get in for 7 weeks. The next person says, well, my wife needs a neurologist, but the next available appointment is a couple weeks out. And so, you stop and you ask yourself, like, what would have happened had you built online scheduling? Technically, it would be easy to build online scheduling, but had you done that, it would have just been faster and easier to see that you can't get in, right? The problem was, new appointment availability for new patients. And so they're a completely different set of solutions. And so when you fall in love with a solution, you end up going down this path that is often not the right path. And I think the things that we really developed from a techniques and methodology standpoint were all about how do you get deeply enough immersed. People can't tell you what to do. They can't articulate their need. They can't, reveal to you the solution very often. They can tell you about their experience. They can tell you about their needs. You can learn by observing, and that's what you have to do. You have to get deeply embedded and just see everything and see all the things that they can't articulate or don't remember or not even aware of. And once you get that deep into what the problem is, you can generate a whole bunch of different directions.
Yeah, no, it's fascinating. I think this notion of reframing is. I think I told you I use it myself. I used it just recently when I was writing about police reform and the notion of defunding the police, and I had to stop and pull a Roy Rosin and ask myself, what problem are we trying to solve for? And it dawned on me that whether you fund the police or defund the police, that's not going to make them less brutal or more racist. And so if that's the goal, let me look at what other ways there are to get there. And how much of that, now that wasn't me doing the 5 so whats, but I at least applied that lens as to defining what the real problem is. What are the 5 so whats? Walk us through how you use them.
Yeah, I mean, the 5 so whats are, more people are familiar with the 5 whys, where you just keep asking why, till you get down to the root of the problem, and you're tackling the root and not the observable symptoms. The 5 so whats is the same, but in the other direction, right? So you're basically saying, what are you really solving for? So when somebody comes up with a solution, human beings think in terms of solutions and specifications. That's just what human brains do. Good people, bad people, all people. And so what's really useful is to capture the experience that represents, right? So, one of my really good friends was there at the beginning of Gillette. And, and I always, loved this story. The early Gillette story was they go out, they do research, they try to figure out, this was long before they became a multi-billion-dollar business and before they're bought by Procter & Gamble. And they're trying to do the right thing. They're trying to understand the needs, and they start asking people, what should we do? What do you need? What do you want? And pretty much everyone says, I want a sharper blade, right? And, so if you do the 5 whys, you might do if you think that the problem is that the blade is not sharp enough, the 5 whys will get you somewhere, right? You go back to your team of industrial engineers, mechanical engineers, you say, hey guys, the problem is blade's not sharp enough. And you might change the materials, you might change the machining to get to a sharper blade. But it's very different than the 5 so whats, because in the 5 so whats, you're like, well, hey, tell me what would be good about a sharper blade? In other words, so what about a sharper blade? And people look at you a little funny because they're like, well, what don't you get about this? And they'll say, well, if I had a sharper blade, I'd get a closer shave. You're like, oh, closer shave, I get that. Hey, what would be good about that? In other words, again, and now they're like, wait, what? You're supposed to be an expert in shaving. What don't you get about a closer shave? That's the whole point. But if you pursue that, what you hear is someone saying, look, I hate shaving. I want an outcome, which is like no whiskers, but I hate shaving. So, I want to not shave so much for the same outcome. And once you do that, you get to a completely different place. The multiple blades, I think they're up to 7 blades now. The way that works is the first blade actually picks up the hair and the next blade cuts at a point that's normally below your skin. Right? So I don't care how sharp your blade is. You can't cut below my skin. And of course, this is how you bust categories, right? Once you realize it's how long before the hair comes back, not the sharpness of the blade, maybe nothing about blades at all. It's like, hey, I'll go invent a trying to get.
Sorry, that was at my end. Sorry, man.
Yeah, no worries. So that's the thing, right? You peel back. What are you really solving for? And you get to these more emotional states. You get to these things that are harder to articulate. That they come into, what is it really that's happening? And it could be I'm cutting myself. It could be I just hate. I don't have the time in the morning to do it. There's something about it that aggravates me. All the wetting of the face and just putting on shaving cream. So it's like, what's really going on, and it's not the sharpness of the blade. So that's how you unlock yourself from these kind of presumptive or overly prescriptive solutions.
I just love that. I love that story, and it opens up your mind to the possibilities of problem solving. So let's fast forward to March of this year, and we have an oncoming pandemic. What problem were you presented with, and did you have to do some reframing to then think about what your priorities had to be at Penn Medicine?
So it's so fun. It's like hazy now. It's not even that long ago, but like so many things have happened since March. What I remember, at least, whether this is true or not, I'm not even sure. What I remember is being aware of what was going on in some of the places that hit first. And what I remember, there's this kind of like fear, there's this concern of, you don't want to get overwhelmed and overrun the way you're seeing happen in some parts of the world and some parts of the country. So it is one of the things I love about Penn is that, this was not the innovation center. This was everybody. Everybody at Penn Medicine sort of like dropped everything and said, look, we've got to be on point here. We got to be absolutely on the ball and nail this. And so across every, interdisciplinary area, my clinician colleagues, the administrative folks, the leaders, the frontline, all the folks on the care team basically said, look, there's some things that we have to get right really quickly. We have to lock down and control, the spread of infection. Our chief medical officer is a gentleman named PJ Brennan, who's also an infectious disease expert. And I remember PJ sort of stood up and stepped up and sort of became the head of this. And there was sort of like this traffic cop directing of there's a whole bunch of things we need to do fast. People in the emergency room saying, hey, we can't have people coming into the emergency room in a crowded space. We gotta understand what's happening with patients. We gotta do it in a way that's safe. Other of my colleagues, David Ash and a bunch of folks that were in the sort of the remote monitoring part of the world, I remember, immediately reacting and saying, hey, we need to keep people safe and we need to keep them out of the hospital. We don't want our ICUs to be overwhelmed. We don't need our hospitals overwhelmed. And, coming up with these just beautiful platforms that, again, they're probably every discipline and every functional area you can imagine, coming together to say, we have to do super fast problem solving. And it really was executional. You had days to do what you might normally do if you're going fast in weeks, and if you weren't going fast, it might take months or years. So they ended up standing up these solutions that would monitor people at home, so they never have to come in. And that was over 4,000 people now have gone through that. Let's keep them safe and hover over them and watch them while they're at home. Other people start to realize the trauma at the front line. I remember Lisa Bellini on the School of Medicine side, working with a couple people, actually Cecilia Lips, who's a phenomenal psychiatrist and just a tremendous designer on my team, a woman named Kelly Kugler, saying, boy, we're having trauma, we're seeing our colleagues really being overwhelmed by these situations. We need to do something quickly in the mental health space. And that team spun up a absolutely brilliant mental health application in 10 days. Actually, with the help of a lot of people, some of the people I see on this webcast, actually, Chariot Solutions jumped in to help, and other community partners did just some fantastic work to help us put things together. That was nourished, for feeding the frontline employees. But Transmogrify was the company, the development firm that jumped in. All these folks in the community jumped in to just help put things together. And it was just brilliant. There were 42 projects I think I can think of off the top of my head, and we can go into as many of them as you want, that showed an entire body of Penn Medicine responding and reacting incredibly quickly. And I think Philadelphia as a whole, actually, as horrible as the overall epidemic has been, actually handled it relatively well. We never did get overwhelmed. I think a lot of people were successfully kept out of the hospital, were triaged appropriately, because of Nourish and what Chariot did. A lot of people were fed because of, Cobalt and what Transmogrify and our team did. A lot of people got mental health services they wouldn't have got otherwise. And it just sort of goes on and on and on. I think the thing that I may be most interested in a sort of a forward-looking is that a lot of the care models that we had started before COVID, where we were really doing them for value, we were doing them to reduce the total cost of care, moving care to the home, out of the hospitals when we could, that just got accelerated. Things that we used to do for value, we started to have to do for safety, right? Things that we did because, we wanted to reduce the cost, we had to do because, we had to be contactless. We couldn't be touching people anymore. So now we're doing it remotely. So I think that the number of models that transitioned and the pace at which they transitioned was remarkable, partially enabled because payment followed suit. We actually got paid for doing things that normally in a normal circumstance you wouldn't get paid for some of those activities.
Well, for the layperson here, tell us what COVID Watch and COVID Pulse is. And
sure.
What a lot of these, and then I have a follow up on what all these innovations have in common. But tell us sort of what they
yeah.
do.
So, so COVID Watch is a really interesting program, and it's still going strong today. So before COVID, a whole bunch of people across Penn in our Connected Health Group and in our Innovation Center sort of collectively realized that if we're going to get to high value care, we need to see and know all these things that we normally don't see and know. So a bunch of people, Kevin Volp, David Ash, other colleagues, wrote these papers 8 years ago or so, talking about this idea of automated hovering, and they called the term the other 5,000 hours, that most health things happen when you're away from us, you're beyond our walls, you're not in the office, you're not in the hospital. And so we had been developing platforms to manage those situations where we could stay in touch, where we could stay connected. We could communicate with people before they came in, we could stay connected after they left, right? And in fact, right before COVID, one of our teams, led by some just fantastic pulmonologists that we work with, Vivek and Mike, just terrific doctors. We had done this project with COPD, where there's this interesting question said, if we knew that exacerbations were happening, that people were getting worse, could we see that sooner than we usually see it and intervene sooner and prevent them from coming back into the hospital? And so we'd send them these daily text messages, right? We'd enroll them in a program. They would receive daily text messages. How you doing? You feeling better, same, worse than yesterday? And based on their simple replies, right? There's no UI, there's no friction here. It's a frictionless system. We could deploy help to the people who needed help. And in fact, that did keep a lot of people out of the hospital, which is much better for the patient and better for the overall cost of care. As COVID developed, what happened is, well, gee, that's kind of similar to some of the things that we need to do now during COVID. There were a lot of symptoms, a lot of triggers that people worried about. There's one that really stood out, which was trouble breathing. And so what would happen, and again, across PJ in the CMO office and Bill Hansen, who's our Chief Medical Information Officer, and the Innovation Center, there was this understanding that a lot of these people were going to be calling in. They had set up a hotline. They'd set up resources to handle some of that volume. A lot of these people, they really didn't need to be in the hospital. If we could stay connected, if we could monitor them, if we could understand how they're doing, we could keep them at home, right? So what was happening is we were signing them up into this remote monitoring program. And again, they get a daily text message. How are you? How are you doing? Are you having more trouble breathing than you were? And at any point, they could text that they felt worse, which could lead to, another intervention. And so that idea that you are seeing things as they develop earlier when they're simpler, they're less complex, and they're less costly usually, and that you could translate that to a COVID situation worked really well. And that's what COVID Watch really is. It's this two-way texting and program where there are escalations to clinical people, and my clinical colleagues can manage them effectively and have managed them incredibly effectively. So, I'm very proud of everyone at Penn for basically putting together this really comprehensive program. That spread to pregnancy, where there's now COVID Watch for pregnant women. It's spread to cancer, where there's a different pool and a different way of managing people who might be immunocompromised. And the Pulse program, where there's a belief that maybe if we have a slightly a patient is in a little bit worse shape, getting a pulse ox and getting pulse oximetry would be useful as well. So that project branched into more specific deployments of the same concept.
So what's interesting about this is that people had cell phones before COVID. So are we learning that has this taught us that there will be post-COVID this idea of two-way communication in an ongoing way? Are we witnessing the changing of how healthcare is delivered as a result of having to pivot to these kind of innovations?
Well, there's no doubt. I mean, I think it's pretty widely known now that you saw a lot more telemedicine. We've known for a while, technically, we can deliver a lot of care remotely, that, probably 70% of the time we don't need to touch you or smell something or otherwise have hands-on. But, it was very difficult for a whole bunch of logistics reasons and policy reasons, frankly, and payment reasons. So that relaxed, and it was so great. I don't think you'll see it going back, frankly. But, again, these things started before COVID. In fact, one of the first successes that came out of the center was this program called Heart Safe Motherhood, which was one of the first times we realized that the preferred modality of communication was the phone, was a mobile phone, and frankly, texting, right? They didn't want to call, they didn't want to email. And these are younger women. Texting was what they did all the way through their appointment. And that insight was at a time where texting was not a allowed modality, right? Like, you're not really allowed to text with your patients. And so it sort of is one of these fun innovation rules where you don't ask, can I do something, right? You ask, how can I do it? Because can I might end up with a no, and you don't really like no's, right? So you say, how can I do it? And so if you said, can I, the answer probably would have been no. But when you say, how could we start texting with our patients? The answer is, well, if you get certain permissions, if you consent them, well, there are ways we can do this, which was enough to get off the ground. And, what that team did, again, just shouting out the incredible people who led it, Cindy Srinivasan and Adi Hirschberg on the maternal medicine side, and Katie Mirage, who's on our team, they started to do this work in a way that while the woman was in office, you sign them up, you give them a blood pressure cuff, and off the shelf, not fancy, no Bluetooth, just, send them home the blood pressure cuff and start texting them. What had happened was that, ACOG, which is a professional society, had been very clear that if you want to keep women safe, you need 2 blood pressures, in the first 10 days after their discharge, after they go home, after they're no longer with us, when we don't see them, right? Normally, we would have no idea what was going on, and people would get worse and have strokes and can die, right? And this is a terrible, terrible situation. We all know in this country, maternal mortality and morbidity are going up, not acceptable. Right? So this team said, no, we're not going to let that happen. We're going to insert ourselves into that process. We're not going to force you to come back in for appointments. We're not going to force you to, disrupt your daily life. So they started sending text messages. We need these 2 blood pressure values. We used to get 2 blood pressure values for nobody. We didn't have that for a single patient before they started this intervention. Right? We might have 1 for about 15% of the population, but we did not have 2 for anyone. They iterated on this program, right? Texting with a woman, trying to get the text back, and if it didn't work, trying different things. Text a best friend, try different times a day, personalize the message with the woman's name or their baby's name. And you iterate, you figure out something that will work, and boy, did it work, right? They got to a point where they had blood pressures coming back from about 90%, 2 blood pressures from over 80%. Don't forget, that used to be 0. They took the readmission rate. So this used to be the #1 driver of women coming back into the hospital and having morbidity, right? Things like strokes and seizures. It was the #1 driver at Penn. It was about 20% of maternal mortality. It was about 1/3 of OB morbidity. They reduced those readmissions 80%. They reduced the morbidity among young women who had new babies. Like, it's terrible when anyone's affected, but when young people with families, it's just an awful thing. They reduced 80% of that problem by going to a low friction system where we simply stay in touch, right? This was long before COVID. So I think that we knew, right? We knew that these models were better models, but making them fit within the payment environment, within the business structure is a more challenging exercise.
I love that, and I love the how can I do that rather than can I do that. I am going to totally use that in all aspects of my life, because it's the way you can actually get to yes when you're faced with a roadblock. Hey, Shaman, do we have questions? We've got Roy for about another 15 to 20 minutes.
Yeah, why don't you go ahead and ask one more question? I'm going to invite some people to the screen.
Well, there's one story that Roy, you tell that I just love, which is the Embrace baby warmer. Can you give us quickly that innovation?
So that's another innovation that kind of comes back to the way you look at a problem, right? So this was there's a number of Stanford students. This was years ago now, where these Stanford students wanted to tackle actually this very similar problem we were just talking about, but in this case it was the baby risk, so very premature, low birth weight babies. And if you go far enough back, these babies who have a hard time regulating their temperature would have a very high mortality rate. And so at some point someone comes along and invents an incubator, and that saves a heck of a lot of babies. But they realized in at least parts of the world you still had an extremely high mortality rate. And babies were born in outlying areas, they wouldn't even make it to the incubator. So, there's this problem statement you can imagine, right? So get the baby to the incubator faster. And the thing is that incubators back then, they cost $25,000 and they required continuous electricity. And if you go to a lot of developing nations, the only places that you can have, $25,000 in continuous electricity with the electric grid, are the big cities. So for babies being born in outlying areas, it's not working so well. It made sense to think that the problem was getting them to incubators faster. But, when you do the sort of the so what's piece, right? What would be good about getting them to an incubator faster? What you realize is, no, it's not getting to the incubator faster. It's getting to a stable, appropriate temperature faster, right? What that team ended up doing is basically designing something that looks like a little sleeping bag. It's like a little sleeping bag that has a little layer of wax that can keep the baby warm. Doesn't require electricity. Wax can be heated over a Bunsen burner, and it's one of these things where it costs 1% of the oil solution. It didn't require electricity. But I guess one of the things I like about that story more than the fact that they changed the problem definition from get to an incubator faster to how do you get to the right body temperature is that if you go back to the ethnography part, the immersion, getting embedded in the world, the context part, in most of these areas, women really practiced kangaroo care. Like they wanted to have the baby against their body. They wanted the baby's body against their body. So you could do this thought exercise. What if they had invented a solar-powered, $250 incubator? So it was also 1% of the cost, and it also didn't require electricity. Would it have worked? Well, maybe not, right? Because if the woman wants to keep the baby against her body, she probably doesn't want to put the baby into a machine. And if you don't use it, it doesn't work, right? So you have to design something that not only is technically and functionally accurate, that theoretically can achieve the outcome, but that people will use. And if you don't get rid of the friction of use, you're not going to achieve the outcome you want. So much of what we do nowadays in healthcare is looking at the friction of use and removing that friction of use.
Thanks, Roy. And now we're going to move on to Miriam, who has a question for us. So go ahead, Miriam.
Hi. So I'm coming from the perspective of a patient, and my question is, how can doctors and patients better work together when we have very rare conditions? Because I was born with a set of birth defects called VODR that almost no doctor has heard of, which is very frustrating, especially in adult care because it's mostly focused on children.
Yeah.
So it's like, how do you better work with doctors when often they have more knowledge of, say, asthma, where my symptoms sometimes present like asthma, or they might present like other conditions, but that's not what it is, and there isn't that knowledge. Yeah. So what's some advice, to better have the patients and doctor work together in that case?
Yeah, communication, I don't know that there's a silver bullet to that. So there's so many things to tease apart in what you're talking about, and I'm not an expert in that area, and I want to be clear about that. Mm-hmm. So part of it is triage, part of it is finding the right doctor, right? Part of it is making sure that the time used together is spent well. There's a lot you're seeing now in development where I think doctors are getting better at communicating. I hear my colleagues and the people I think of as some of the best doctors I know and work with, their communication is wonderful because they're asking what would normally be unusual questions like, hey, what are your goals and what are you worried about? And sometimes when care is shoved into these short little appointments and it becomes too much production almost, you just have to crank through things. It's very hard to get to the core issue that the patient really cares about because there's a bunch of things that the doctor needs to do. That's sometimes exacerbated by the systems that the doctors need to use that require them to pay attention to the system, documentation, other things, instead of paying attention to the patient. So I think there's a couple things that we've been thinking about, and there's a bunch of teams at Penn that are working on this that I find fascinating, but we don't know yet which are going to work. I think part of this is moving some of the pieces that used to be inside the appointment outside the appointment, right? So some of these, when I talk about some of those connectivities where we can be texting back and forth, when you can get that going ahead of the appointment, even after the appointment, and see things as they evolve, get a better sense of symptoms, when they're happening, what's happening, how are they flaring up, how are they being manifest. A lot of times people have a symptom show up in an appointment 2 weeks later, and it's hard to describe, it's hard to capture exactly what's going on there. So the patient has a hard time expressing it, the doctor has a hard time understanding it. So I think, capturing it closer to when it's happening, we're seeing a lot of success there. In fact, we're seeing this in things like oral chemo and other very complex, diseases with complex regimens. Like, as you're having a back and forth, you're actually discovering things we never knew about more complex situations. The triage one is interesting too. We're seeing a lot of kind of front doors being put on now, and we're trying to do this as well. And we did this actually during COVID, where sometimes when we can ask a bunch of questions before you get to us, we can route you in a different direction, maybe connect you with the right doctor or someone who has the right specialty more quickly, than we would have otherwise. I'm also out of the Department of Medicine at Penn. One of the things I'm actually really excited about too is they have done a phenomenal job with e-consults, where you're with one doctor and that doctor can be in an electronic consult with a specialist. And it's just fascinating, both from a patient experience and from a doctor experience and from a total cost perspective. What that tends to do is it's actually unburdening a lot of the specialists from care they don't really need to be doing. A lot of people go to specialists who don't need that specialist, and then the specialist doesn't have time for the people who really need them, someone like who might be in your situation. So, we're seeing an evolution in those directions, which I think is probably part of, the problem. But I think it's probably a lot deeper. I don't want to oversimplify what I think is, when you have a complex chronic disease, those are hard, and there's often underinvestment the same way there's underinvestment in orphan diseases. So it really takes a special person to kind of, to work with you and work with you carefully. I mean, luckily, the clinicians I work with are these just wonderful mission-driven people who put in the nights and weekends to do that kind of thing, and you find the right one and great things happen. I invite you offline to tell me more about it. I'm also,
that'd be great.
Yeah, no, I'm very happy to. We have a couple people.
Complex issue of it is the longer appointments and
yeah.
There's
a few people.
But thank you for answering the question.
And there's just no escaping the fact that there's a couple of people who are just brilliant physicians, and I'll see if I can connect you with one of those people.
Great, and now we're going to move on to a question from Anne.
Hi, Roy. Thanks for being here. Really great chat. I took a lot of notes. I love the how strategy. My question is around your creative problem solving at UPenn, implementing tech and its impact on healthcare workers. What were your experiences in terms of, resistance or feedback from frontline workers who are adopting innovation, or, did you find that their jobs are augmented? What is UPenn's sort of approach in terms of like training opportunities or strategies to avoid displacement of healthcare workers, things like that?
Yeah. So I've been delighted from the time I walked in the door at Penn 8 years ago. What I found consistently was people who support the idea of making things better. I mean, these are largely mission-driven individuals who want to make the world a better place. There are innovation techniques that I think are really important because it's not uniform, right? There are areas that are pulling more for change and other areas that are maybe not ready for change quite so much. And there's a big difference in success rate when you work with someone who's pulling for what you can do instead of you having to push, right? So finding clinical champions, care teams that really care about it, executive sponsors, is a big part of being able to overcome inertia, right? And get going. And overcoming inertia is a really big part of the game. We've had no trouble finding those people. I mean, so people across Penn are innovating all the time. And people at Penn were innovating long before we had an innovation center. And they're innovating well outside of the innovation center today. It's kind of happening all the time by everyone. We bring some specific methodologies to it that we think can accelerate and sort of expand some of the solution sets. But the reality is that finding those people who want change is a key part of the formula. Working with them first, working out the kinks, kind of refining and iterating with those people who are sort of, evangelists, if you will. We do a lot of training. To the other part of your question, we try to teach some of these methodologies so there's kind of a fertile soil to work in, right? People who kind of think this way, who explore this way, who don't get locked into solutions too quickly, who are willing to iterate, who are comfortable that it may not be right out of the gate, and that's okay that it won't be right out of the gate, but you'll see what did we learn and what can we build on that we might have learned in the first iteration. So that training is a big part of it. Penn has a really wonderful academy where people get trained, and just it's sort of a constant throughput of training and investment in that training across all disciplines. So another one of my colleagues, Cindy Morgan, really runs that part of the world, and it is really extremely well done professional training that includes and incorporates these methodologies for creative problem solving.
Thank you.
Well, we've got kind of a fan question here before I give the floor to Larry to kind of close it off. But someone asks, how does technology and innovation show up in your personal life? Do you all have all the latest gadgets, robots, question mark?
No, I definitely don't. In fact, I'm like the last person to adopt new technology nowadays. I think I'm the only person on my team who's not on Slack, for example. Like everyone else communicates on Slack, and I probably drive my team crazy by not being on Slack. But no, I'm not an early adopter. I mean, I think one of the things that I actually think helped me in Silicon Valley was my ignorance. I was willing then to ask dumb questions. I'm willing to say when I don't understand things, and that's frequent. I frequently don't understand things. But I try to think through them logically and try to make sense of it. And that sort of being a non-expert actually helps people who are truly experts kind of sometimes step back and say, well, wait a minute, boy, I'm seeing that through a new lens. I'm seeing that through new eyes, and I think that can help. In healthcare, it was similar, right? So I couldn't have done any work without being paired with clinicians and with people who actually knew something, right? Healthcare is not a place where you can be successful not having healthcare knowledge. So you certainly need, that deep expertise. But again, when I come in and I say, well, that doesn't make sense to me, sometimes it is that ability to be a little bit behind that doesn't harm you so much, and it does sort of start an interesting conversation.
Cool. And we have one last question. Margaret's asking, how can we get self-service flu shots to avoid having to go into a drugstore or a doctor's office? So I guess a future-facing question.
Yeah, it's really interesting because as things move to telemedicine, Matt Presser actually leads our primary care line is asking this question, like how do we take the things where you still need to touch, labs or blood pressures or, other things, vaccines, and not require a touch even for those things, just to make all the other virtual worlds work even better. There's a lot of innovation going on in that space. There are companies that send gadgets home where you can be taking your own images, you can be listening to the heart, you can be listening to the lungs, you can be, looking in the ears, taking temperature, taking blood pressure. So there are certainly remote devices that do a lot of that. There's a lot of human behavior questions here about would people vaccinate themselves? It's a answerable question. It's a testable, thing that it's certainly validatable. I certainly don't know any ways of doing it right now. I'll be transparent. But thinking about moving some of those out into the community, making them as convenient as possible, removing as many trips as you can possibly remove is part of the idea. I mean, when I think about like one of my favorite projects that we led, again, it was a pre-COVID project, but it highly relevant in the COVID days. There's a bunch of my colleagues in plastic surgery, actually, so Joe Soletti and Mike Tecci. So they are the absolute leaders in breast cancer, breast reconstruction. And they worked with a couple people on our team. Kat Lee, who's an emergency room physician, and Lauren Hahn were two of the leaders there. And they looked at this world of like what happens after the surgery. They said, well, after this surgery, there are 5 visits. There's a 90-day period where you have to come back 5 times because Penn is sort of a center of excellence there. People would come from far away, so it's 25 hours of travel time across these 5 visits. And when they looked at like what do we really need to do in these visits, and they found that they actually could get rid of 4 out of 5 of those visits, and they did. They eliminated 4 out of 5 of those visits. Sometimes it was people coming to your house instead of you coming to us, and maybe that's what vaccines ends up looking like, right? So someone who might be a home care nurse is coming to you instead of you coming in. Sometimes they actually just eliminated the need, if you need to see the surgical site, take a picture of it, right? And we can send you specific questions about, how you're feeling and how you're doing in your range of motion and what's going on in terms of your pain. So some of that can be just eliminated because it doesn't require a touch. But the things that do require a touch, either we come to you or somebody at some point does invent a tool, and we've been able to do that in a few places where, now it is self-serve. A lot of things now, clearly, in diabetes care and others, there's a lot more self-serve going on. Could that get to vaccinations? Absolutely. Certainly, diabetics certainly can inject themselves and do so on a frequent basis. I think that there are ways, with thinner needles and others that make that less unpleasant. And there are even other ways to get things into the body as in across the skin. Sometimes certain things can be absorbed through the skin that doesn't actually require a needle. Right? So I think the evolution of this, again, if you want to be crazy about these, so what, it's not about getting the shot, it's about getting the thing into your body. Maybe there are other ways to do it. You've seen in cancer care this evolution from infusion to oral chemo, right? So things that can be self-administered at home. So, you're also seeing it, under Justin, one of my colleagues, Justin Beckelman, has been working on moving the actual infusions home. And you've seen a great acceleration of that because of COVID as well. But when you go from infusion to, taking oral chemo, in other words, medicines, you've changed the mode of delivery such that it's something that's easier for someone to do themselves, right? So again, I'm not going to assume it'll necessarily be people having to inject themselves, but moving to that much greater level of convenience, I'm with you. I'd love to see it happen.
Great, thank you. Larry, if you want to ask a final question, close out the conversation.
Yeah, that'd be great. Thanks, Shabin. Great job, Shabin, yet again. Roy, as you've been talking, it occurred to me that you are also a citizen of Philadelphia and the Philadelphia region. Have you given thought to what the problem is that Philadelphia ought to try to solve? Have you taken reframing challenge to look at Philadelphia writ large, and do you have any thoughts along the lines of? And I'm asking for advice because one of the reasons we create the Citizen is to try and make things better. But what if we're trying to solve for the wrong problems? Do you have any thoughts along those lines?
So I think I've talked about a little bit. I don't believe there's a silver bullet. I follow the multitude of issues pretty closely, and I think we have serious problems. As do many large cities, in areas like education, in areas of racial disparity, in areas of prison reform. There are things that we're doing that I think are working. There are things, as you often said, that we can steal that would work better. There are some areas where, our group at Penn has taken on something. We said, because it's Philly's problem, it's our problem. I'm incredibly proud of the work that our team has done in the opioid use disorder world. You have folks like Jean Marie Perrone, who's a doctor who's led there, and a team that is just incredible. A lot of people may not know about certified recovery specialists, but Nicole and Bryant, who are two incredible CRSs, who are basically people who are peer recovery specialists, looking at this problem where Philly has the biggest problem of any large city in terms of opioid-related deaths. If you go, not too far back. And doing something about that. So I think, what you're trying to do is get the right people to tackle the right problem. And of course, when you think about changing the problem, every time someone tackles one of these hard, complex problems, it changes. Like if you go from rehab and detox in the old days of taking care of a big problem like that, you have like a 5% success rate. I look at that team, and they've moved up to like almost a 70% success rate, right? So it is changing, and that's of course using things like BUP and just completely changing it to a harm reduction approach. So I think that reframing the problems will be relevant in every single place that we have to go, but you need the experts in those areas to start leading and to start experimenting. I don't see enough deliberate experimentation. I get frustrated in the world where there is live experiments and we don't learn from them. I mean, you can look at things that range from trickle down or what Brownback did in Kansas around taxation, and say, well, it didn't work, right? That is just something we should never do again. And that was a live experiment. The policies around COVID and masks or social distancing, opening and closing, live experiments. We're not doing enough of these experiments and then really carefully, rigorously measuring them to say what works and what doesn't work. Some people are doing that more now, but I think we need a heck of a lot more. Some of them are more intractable, but there's progress. If I had to pick one area, I would probably pick education. I know it's a long-term one. It doesn't fix everything overnight. Nothing fixes everything overnight. But, I think we have such an unfair, unlevel playing field that education, I find, at the core of so many things. And I kind of couple that with some of the other ones that we think of in the social determinants world. Larry, the impact program that Shreya Kangovi built, which is just an amazing program, like taking people out of communities, the community health workers who have shared experience, shared background, to work with vulnerable populations about these really intractable problems, homelessness and food insecurity and addiction and abuse. And, in healthcare, it's a consistent formula, 5% of the population driving 50% of the cost. And healthcare wasn't designed very well for a lot of these vulnerable populations, and there are even trust issues, right? Shreya comes along with people who come from the communities and redesigns everything, rethinks everything. How you find these people, how you train them, hire them, how you deploy them, manage, track over time, how you engage in a way that's truly empathetic and caring. And, when you see results like that, right, you sit there and you go, well, wait a minute, she just eliminated more than half of all hospitalizations for the most difficult, vulnerable populations to manage. And you know what else? Wow, she's now getting a $2.47 return on every dollar you invest, right? I mean, that's a completely different way of doing healthcare, doing it with these community health workers, the same way that CORE, the opioid program, works with Nicole and Brian as peer specialists. They're not normally part of healthcare. It's a completely different type of solution with people who are close to the problem. And it's not great because it's lower cost. It's great because they are the best ones to solve the problem, right? So you're rethinking problems based on people who are closest to those problems, and you're going to make a lot of progress.
That's great. I share your frustration at the sort of reticence, particularly in the political, in the governmental realm, to experiment, because there is no political payoff for failure. Right? You only get punished for a failed program, but people forget that the New Deal was a bunch of experimentations. So I'm right there with you, and I look forward to your intellect informing more of the light of Philadelphia as we go forward. I can't thank you enough for taking this time with us. And to the citizen community, I will rise again. You will see me, although it's often not a pretty sight anyway. But you will see me again. We will announce our July programming next week. Let me know if you guys like that idea of a solutions open mic night. And thanks everyone for coming. We'll see you soon.
Thanks, everybody.